My name is Dr. Flavia Nelson. I'm a neurologist with training in multiple sclerosis. I've been dedicating my life to treating patients with MS as well as doing research in MS-related cognitive problems for the past 16 years. And I used to be at the University of Texas in Houston until 2017, and I've been at the University of Minnesota for the past almost 3. So other than that, I'm originally from Mexico City, and both of my ex-husbands had a parent with MS, which was kind of interesting. So hopefully the third one won't or will, who knows, but I'm not sure there will be a third one, but anyway, I just thought it was an interesting fact. So I'm originally from Mexico City, but my first husband was from Minnesota, hence the Nelson. And like I said, I'm very familiar with MS, not only because this is what I do for a living, but because of family ties. And most of my research is focused on cognitive dysfunction, but using MRI to try to see if we can actually pick it up on the MRI, which is we're not quite there yet. But so that's about, just a short summary of who I am. And with that being said, I welcome you to this talk. I appreciate you joining. And again, I hope you learned something. So I'll start by saying we call it cognitive impairment or cognitive dysfunction. And it can be scary, or one of the most scary symptoms of MS, because nobody wants to lose their ability to think clearly. Okay, now something interesting about it is that we used to think that didn't happen in MS. Some people call it dementia, but dementia, I would say, is a strong term. We don't really see full-blown dementia as you would see, say, in Alzheimer's, which is, people don't really remember who their relatives are or their spouses are. We don't see that. So we don't really call it MS-related dementia, because it's just an impairment. It's not, you're not thinking normally, it's not the way it should be, but it's not impaired to the point where you cannot not function. It very rarely gets to that point. It just impairs your ability to function. And we used to think it was rare, but now we know it's actually a lot more common than we think. Next slide, please. I think we skipped one. There you go. So the reason this happens is because we have the impact of inflammation on different parts of the brain. It can impact the myelin, which is the protective layer around the nerves, the axons. And the axons, which are every individual nerve is called an axon. And then we also have something called neurodegeneration, which means the cells kind of die after some of the damage from the inflammation. They kind of die afterwards, years later, not right away. And that neurodegeneration can cause what we call brain atrophy. And you've heard the term muscle atrophy, which means, if you don't use your muscles, they're going to get smaller. And that happens to our brain, but it's not because we don't use it, although that can contribute to it. And we'll talk more about, how to keep our brain in shape. But basically, brain atrophy happens to all of us. As we age, we lose brain volume. The brain shrinks and we're not as sharp as we used to be. Unfortunately, in MS, the process is a little bit faster, and that also contributes to people not being as sharp as they used to, and less than they would be if they did not have MS. Next one, please. So this is what we call brain atrophy or volume loss. On the picture on your left, letter A is a normal brain. And then we see how this patient with MS, as time goes by, say she was 40 when she was diagnosed, and then as time goes by, and we see letter B, The spaces in the middle, which are full of fluid, you know, the dark spaces in the middle of the brain are full of fluid. They look bigger. And then as we move to the right and we see the last picture on the right, letter C, we see that those spaces are a lot bigger, which means the brain, the actual brain, which is the gray part, is thinner. And there's a lot more space inside the brain. So that's volume loss. And that volume loss comes from not just losing tissue around those spaces, which are called the ventricles, but also losing tissue everywhere in the brain in a microscopic kind of way. So we have, in MS, we have inflammation that is easy to see on the MRI, right? Those big lesions, and we don't see any on this particular MRI, but you know those lesions that your neurologist monitors, and that when they're enhancing or inflamed, that's big, big areas. Those are big areas of inflammation, but we also have microscopic inflammation, which means inflammation we cannot see on the MRI. We can see it with a microscope perhaps, and that sometimes can actually kill cells in a way that creates atrophy. But so it's a combination of the big lesions leaving scars and shrinking things as they heal, sometimes not, and also the microscopic inflammation also causing a little bit of destruction of the tissue, all in their just outside the lesions in what we call the normal appearing gray and white matter, meaning normal appearing because when we look at the MRI, you know, that looks normal. But if we were to look at it under a microscope, we would see some inflammation, providing there was no treatment or the person was not responding to the treatment. So obviously the disease modifying therapies, the medications that you guys take for MS, decrease that inflammation and prevent this volume loss and also prevent new lesions. Next slide, please. Okay, so the damage caused by MS can cause physical symptoms, but it can also cause cognitive symptoms, and those are not easy to see, or sometimes we cannot see them at all. Sometimes the patient is not even aware of them. It's not that clear to them, and we'll talk more about why. Next one, please. So cognitive impairment or dysfunction occurs in up to 70% of patients with MS. Some people, a small percentage of them, can actually present or have some cognitive issues at onset, at the beginning of the disease when they're diagnosed, or and some of them in the early years. Most of the time, 60% of the times, or most people have it in the advanced stages, meaning when they have had the disease for 15 to 20 years. And it's also influenced by disease course, which means if you have relapsing remitting MS and you develop secondary progressive MS, we see it more often in secondary progressive MS because that is the advanced phase of the relapsing remitting phase. Primary progressive MS also tends to have more cognitive impairment. So not as much in early MS, but we can still see it. Next, please. So I mentioned this already, more commonly in the late relapsing remitting phase or the secondary progressive phase. But interestingly, there is no correlation between physical disability and cognitive impairment. So we can have people that are significantly disabled physically, but have no cognitive impairment, and then vice versa, people that have cognitive impairment and no physical disability. So, it is interesting how that can happen, but it's true. And like I said, people with primary progressive MS, they tend to be diagnosed in their 50s, which is not helpful for cognitive impairment because we all start kind of not being as sharp after 50, right? And it takes an extra effort for us to maintain that sharpness that we used to have. before 50 or before 40 even. Next one, please. So the problem with, did somebody have something to say? Okay, the problem with cognitive impairment is that it's often under-recognized or misdiagnosed as depression, stress, or personality disorder. So we need to be aware of this. If someone is not acting right or they look depressed, we may want to check into, could this be a cognitive impairment issue? So cognitive impairment, if you know you have it, or if you are wondering if you may have it, can be made worse by fatigue. So it can also be impacted by medication side effects. So I've had patients that tell me, and then we do the testing and it's normal. And it turned out it was just, something like gabapentin, which a lot of people take for neuropathic pain and such, or other medications too numerous to mention. And also the pattern and the degree of involvement is variable. So, but it tends to be mild to moderate. Again, never severe enough to call it a dementia. Next one, please. So this is important because it's actually the leading cause of unemployment. It does impair daily functioning. It can increase the risk of accidents. It contributes to the loss of social contacts, and once you're aware of it, or people are aware of it, it can cause depression. So next one. Okay, so what domains, we call them domains, are affected? The main domains that are affected are your ability to pay attention, memory, but not the, the memory of like long-term memory, more like the working memory, like what did I just do? What did I have for breakfast? Do I have an appointment today? Things that are, the working memory is like the one that you have to kind of keep remembering things all day, or from yesterday, or from this week, not things that happened a long time ago, like when were your children born, or when did you get married, or, etc. So those two, but also, and the most important one is processing speed, meaning how fast can you process information? Let me give you an example. If somebody gives you a recipe, perhaps when you didn't have a mess, you used to be able to remember the whole recipe in your head and come home and make it, or even come home and write it down. But now you may remember 3 ingredients out of 5 and the first 2 steps, because you couldn't process all that information to actually, what's the word? I'm blanking out. Anyway, it'll come back to me, but you want to be able to store it, which is the word that I can find. There's a different word for storing that information so you can retrieve it. So it may get kind of lost in translation. You cannot actually store it properly because it was going through your brain so slowly that it never got to the storage place, if that makes any sense, right? So, and then last but not least, visual spatial perception, which means things don't look the way that they used to look. And we'll talk a little bit more about what that means. Next, please. Okay, so it doesn't usually affect language and very rarely verbal skills. Occasionally, people will say, I have word finding difficulties, but that's not necessarily your verbal skills or your language. That's more memory. Okay, but your verbal skills are still good. You still speak fluently, you still know your language very well, and you use the proper word. It's just, again, finding that the right word that you wanna say. Next. Okay, so this is a different way of presenting the symptoms. Slow thinking, short-term memory loss, difficulty processing information, visual spatial disturbances, which means You hit the curb with the car almost every time you turn now, or you didn't calculate and you hit the edge of the car with the garage door, things like that. Difficulty with problem solving, decreased ability to multitask. And all of these can actually cause personality changes because it's going to make you irritable not to be able to do all these things. I mean, it does me, and um, just because I'm 50, so I can certainly imagine how somebody will feel if they had all these things to struggle against. Next. So these are examples of what people will tell me in the clinic. I get distracted very easily. I cannot multitask. I have difficulty finishing tasks. I don't feel safe driving. It makes me really nervous. I can't follow directions. And one that makes me sad, I don't want to go out with my friends because I just can't keep up with the conversation. They move too fast for me. And that can cause isolation. And I don't want to see that. So I encourage you to go out with your friends and explain to them that, it's going to take you a little longer to catch up, and just to, they can tease you if they want, as long as they're nice, but keep going out with your friends. That's the important thing. They love you. They don't mind if it takes a little longer, and so don't isolate yourself because you don't feel as sharp as you used to. They care more about your company than they care about how fast you can process information. That's for sure. Next. So what do we do to pick it up? There's a test called, it's a screening test, meaning we can do it in the clinic. It's called the BICAMS. The brief, it stands for Brief International Cognitive Assessment in MS. And it was developed by consensus in 2000. It was published in 2014. And the main person that led that consensus was an American neuropsychologist that I am lucky to do research with, Dr. Ralph Benedict, who's at the University of Buffalo in New York. And this test is a combination of 3 different tests. And one of them is specifically to test information processing speed. One is for verbal memory, and the other one is for visuospatial abilities. But because neurologists in general don't have a lot of time to even do a 15-minute test during a clinic visit, they also suggested just to do the shorter version of the BICAMS, which is one test, and it's called the SDMT, which stands for Single Digit Modalities Test. And that test is a 1-page test that can actually be applied or taken in about, I would say, 5 minutes plus the other 5 minutes to explain the rules. And it's very easy to score. Some neurologists are doing it. We are doing it at the University of Minnesota, and some are not. I think mostly because of lack of time. But the screening tests are available, and the SDMT has been shown to be very, very good at picking up information processing speed problems, which, as we said, is the most common domain affected by MS. So I'm going to pause for a second in case you want to write something down about this test or about screening. And again, it was created with the goal of clinicians and neurologists using them in their clinic. And I know some of us have been able to incorporate it into our clinics, but not everyone. So it is available, but I cannot tell you for sure that it is available at your clinic. You may want to ask. Next. Now, to confirm, say if we do a screening and it's suggestive of it, we want to obviously refer you to an expert who would be a neuropsychologist, not just a psychologist, but a neuropsychologist. They are experts in testing for cognitive impairment. And the testing may take 3 to 4 hours. So they're very thorough. They do everything, all kinds of tests. And there are some tests that tend to be better for MS, and they do those and they do others, and they make sure you don't have depression, and they also make sure you don't have anxiety, because believe it or not, anxiety can also play a role and make your cognition worse. So if you're very anxious and your anxiety is not under control, that can play a role, and we need to control your fatigue, control your anxiety, even your pain, before we can actually say, okay, you do have cognitive impairment. Otherwise, it wouldn't be fair. Same with medication side effects. The problem with the neuropsychological testing is that they are expensive, not always covered by insurance, not available everywhere. They're usually available in the big cities, in the universities, things like that, but not everywhere. And then also, if you happen to be testing when you're very tired because you didn't sleep well the night before or whatever, then the results can be influenced. So it's very important that if you're gonna get tested officially by a neuropsychologist, that you sleep well, that you test early when you're fresh and rested, and then if you don't feel well, would not be like, if you feel depressed that day, or if you feel down, or you didn't sleep well, might not be a good idea to get tested that day, because then the results would not be fair, if that makes sense. Next. So the diagnosis should be made as early as possible, so that we can help you cope, help you and help the caregiver as well. Because everyone, not only the patient and the caregivers, but all the professionals and non-professionals involved in your care should be informed of the diagnosis, so that they don't expect you to understand any kind of instructions easily, such as physical therapy, speech therapy, how to give an infusion, how to take a medication, etc. Everyone should be aware, so that we can make it easier for you. And then we can also give you feedback on, specifically in your particular case, what is your biggest weakness and what is your strength. So even though we have the most common domain affected, and as you know, not everyone is the same, and we need to tell you, okay, this is where you struggle the most, and here are some ideas to make this easier. You have to make a list, you have to set an alarm, you have to do this, you have to do that. So the neuropsychologist also gives you coping mechanisms or tips on how to get around some of these weaknesses, which is another reason why it's important not just to screen and say, okay, yeah, it looks like you may have it, but to have an official evaluation and knowing specifically where are your weakest and stronger areas. And a lot of times, believe it or not, a lot of times I get results that say this person has very little cognitive impairment, but has significant anxiety that is not under control, even though they're taking medication. So it's important to know that as well, because if what's really hurting you is your anxiety is not under control, or your depression is not under control, then we can make that better. A lot easier than cognition, that's for sure. Next. So this is basically studies that we've had in terms of patients and what we've learned. So for example, Maria Pia Amaro, who lives in Italy and is one of the persons that has done the most research on MS-related cognitive impairment, unrelated with MRI especially. This is from 2001. I wasn't even a neurologist yet, but she looked at 45 patients that were early in their MS and in their MS onset, and she looked at 37 patients that were not impaired at the beginning of the testing, and then followed them for 10 years, and at the end of the 10 years, only 20 of them were still not impaired. So by the end of the 10 years, even though they were early in their disease, 56% of them had cognitive impairment. Next. Now, in other patients that had a high EDSS, meaning they had significant disability, physical disability, but were cognitively normal, you know, when they follow these patients, this is a different study. So they followed 23 patients with a high EDSS, which means important disability. And they also followed 20 patients that were cognitively impaired, also with similar high disability. And what they saw is that 3 years later, the subjects that were not impaired at baseline were still not impaired, and the subjects that were impaired deteriorated. So in other words, 3 years doesn't make a big difference in terms of, you know, taking you from normal to impaired, even if you have a lot of physical disability. But if you have high disability, physical disability, and you have cognitive impairment, then it can get worse in 3 years, or, you know, fast. Next. Now, what about MRI? How do we use MRI to suspect or support a clinical diagnosis of CI? Well, the answer is it's still controversial. Why? Because we have all done so many studies, and we find a lot of what we call correlations with cognitive impairment, meaning, oh, if we see brain volume loss, then people tend to have cognitive impairment. If we see lesions, too many lesions, then we see cognitive impairment. Or if we see lesions in the frontal cortex or in the frontal, in the forehead, then people have cognitive impairment. The problem with all of those statements is that it's not true for every single person, meaning not everyone that has brain volume loss has cognitive impairment. Not everyone that has lesions in the forehead has cognitive impairment. Not everyone that has, you know, any definition that we see that I can tell you, there's always an exception. So that means that even if I see something on MRI, it's not 100%. I'm not going to be 100% sure that this person has cognitive impairment just because I see that. So some of us that like to do research and look at MRIs, we keep trying to find ways to look at a combination of metrics, perhaps, that will give us that answer. So if we see A, B, C, D, then that means cognitive impairment. And we're still in the process of looking for that. Next, please. So unfortunately, there are also conflicting results, and not every study says, yes, if you see a high T2 lesion burden, people tend to have cognitive impairment. Some people did not find a correlation. And then some people did not find a correlation with the black holes, as we call them. So we have different degrees of correlations, and which means the strength of the data. Okay. Now, when we looked at diffuse tissue damage, remember we were talking about microscopic damage of the gray and the white matter. There's some techniques that, you know, I won't go into details, but there are some techniques that can look at the microscopic features of the brain. Those did correlate with cognitive impairment, but again, not on everyone. So so far, the one metric that I think is the most reliable is functional MRI, which is not looking at the picture of the brain, not just looking at the anatomy, but it's looking at the function. But that one is a lot more complicated to perform, and it's still in the process of being investigated. So, you know, hopefully at some point we'll be able to use it to diagnose and treat, but not yet. Next. So there have been studies that have concluded that if you have atrophy, that can be used as a predictor of cognitive impairment, especially if it's more central atrophy. Remember when we looked at that picture of the three brains, and the one on the right had a lot more space in the middle? That's central atrophy, okay? And also when we see atrophy or volume loss in the frontal lobes, which is your forehead, that has been associated with cognitive impairment. And last but not least, the cortex. So the cortex is the thinking part of the brain. So we need the cortex to think, but we also need the rest of the brain. So think of an apple, a red apple. The red part is the cortex and the white part is the white matter. So the red part is the gray matter, which is the cortex, and the white part is the white matter, which is important to connect all parts of the cortex with each other. Because in order for us to think and to move and to do everything we do, we have to have different parts of the cortex talking to other parts of the cortex and, communicating through fibers or tracks or pathways in the white matter. Does that make sense? So it's important that the cortex is very important, but so is the white matter, because it creates pathways to communicate between one part of the cortex and another. Next. So again, the brain cortex, the cortical gray matter, the red part of the apple per se, is very important, a very important element in cognition. And MS can affect that as well. We used to call it a white matter disease, right? I'm sure you've heard that term. Well, now we know it's not just a white matter disease. It can actually affect the cortex. So the more we looked into these lesions in the cortex that are not so visible on MRI, the more we realize, wait a second, this is not a white matter disease. This is a whole brain disease, and cortical lesions, the ones that we do not see very easily, can cause cognitive impairment, or at least here is as a question, and the answer is yes. If we have lesions in the cortex, which your neurologist cannot see on an average MRI, that can also give you cognitive impairment. But we can also measure how thin the cortex is, and cortical thinning can also be associated with cognitive impairment. So the more we looked into this cognitive impairment and trying to correlate with MRI, the more we learned about MS and realized, wait a second, this is not just a white matter disease. We were wrong. So now we're starting to look at it as a whole brain disease. Of course, it also affects the spinal cord, but we're focusing on the brain for the purpose of talking about cognition. So it's been a very interesting 16 years for me, because when I became an MS specialist and finished my training on it, cognitive impairment was not even talked about, and we didn't really talk much about how MS affected the cortex or the gray matter. And now it's so common, it's just amazing. So we've learned a lot about all this in the past 15 years, and I'm glad we have. Next. So this is your typical, on the right side, your typical MRI. And then on the left side is the first time that we actually did this type of sequence or type of picture where you see cortical lesions, but they're very difficult to see perhaps, and I'm not managing I'm not using the mouse, it's not my screen. But if you look at the top of the brain, and right in the middle, I want to show you that there's two aspects of the brain. There's the gray matter, which is the cortex, the outside of the brain. And then there's the white matter, which in the picture on your left is actually darker. Okay. And then there is something whitish, which is the fluid, the CSF. So first you see CSF. All the way on the outside, you see the skull. Then you see dark. Okay, and then you see the white fluid, and then you see at the top of the brain on the left, you see a couple of spots that are white. In the middle, closer to the middle, all the way at the top, closer to the middle, there are two spots on the right side of the brain. And those two spots are cortical lesions that we don't see on the other scan on the right. So the scan on the right is the scan that your neurologist sees, and we don't see those lesions there because you need special technique to see these lesions in the cortex. But you know, I wanted to show you those two lesions because those were that was the first time we saw them. Next. So what can we do to treat cognitive impairment? I would say the most important thing we can do is try to prevent it. Okay, prevent the occurrence and slow the progression of cognitive decline. Okay, so we have two ways of dealing with it: prevent it and symptomatic treatment, meaning how do we alleviate some of the effects of cognitive impairment? Next one. So we talked a little bit about some of the things that affect cognitive impairment: fatigue, depression and anxiety, pain, side effects from medications, and we didn't talk about sleep disorder. Okay. So someone's asking about a 1.5 versus a 3, and the answer was a 3 Tesla, right in around 2004 when a 3 Tesla was a big deal, and we didn't have 7 Teslas, but now we do. But that was 2004, and it was a 3 Tesla magnet. Thank you for that question. So again, sleep disorders can play a huge role in cognitive impairment. And I hadn't brought it up because it's probably the most important treatable cause of cognitive impairment in MS. Okay, a lot of people are aware of their fatigue, they're aware of their depression, they're aware of their anxiety, and they're aware of their pain, and they're doing something about it. Sleep disorders are very prevalent among MS patients, meaning a lot of people with MS have sleep disorders. Sleep disorders, they need to be treated. It's not just I can't sleep and I need to take a sleeping pill. They're more complicated than that. And we don't do enough sleep studies. So that is important, okay, to make sure that you don't have obstructive sleep apnea, periodic movements of sleep, restless leg syndrome, all kinds of different things that can affect your sleep and consequently your cognition. And then again, if you're wondering if you have cognitive impairment, take a look at your list of medications. Are you taking baclofen, gabapentin? You know, are you taking something to sleep like Ambien? A lot of people like Ambien. There are a lot of medications that can make you groggy during the day. You need them, but they're still going to make you groggy, and we have to find a way to get you to the point where you take the least amount of these medications so they don't interfere with your cognition, or we give you something to counteract those side effects. Next. So there are no FDA approved treatments for cognitive impairment in MS at this point. We do use things like psychostimulants like modafinil and armodafinil, or you may know them as Nuvigil and Provigil, and those are helpful specifically with attention, and they do help with information processing speed. We also use medications that are used for Alzheimer's, but we use them at lower dose. Inhibitors. Unfortunately, some trials showed a benefit and some trials actually showed that patients were getting worse when they were taking these medications. So we have to be careful with them and try them. But if somebody feels like they're not getting any better and they actually feel worse, it could be the drug. So they have to be used very carefully. And they're not FDA approved for MS. They're just what we call an off-label use. Antidepressants definitely help. And there are some remedies that claim to help, like ginkgo biloba and green tea, things like that, although there have been some small clinical trials that did not show an effect. But then again, you know, sometimes it's about the individual. You know, maybe one person doesn't respond to ginkgo biloba and green tea, but another one does. So it kind of sometimes depends on what helps you in particular. There are things that we can all do to help ourselves with cognition. And then there are things that specifically help you, and you need to try different things and see if they help. Now, I want to say something about cannabis. Cannabis, a lot of people like, especially here in Minnesota, it's legal and they use it for pain and for spasticity, but it will make cognition worse. So I discourage daily use or even 3 times a week use. I discourage that. You also have to be careful with CBD oil because more often than not, it does have THC in it. Okay, so again, CBD oil, a lot of times is not pure enough and it will have THC. So that is going to make cognitive impairment worse, especially if you use these products every day. So next one, please. So the most beneficial thing that we can do to help cognition, again, once we have made sure that fatigue is as controlled as possible, depression is as well controlled as possible, anxiety, and we're sleeping well, or you're sleeping well, then cognitive rehabilitation. Okay, and you can do it yourself by buying magazines with memory games, crossword puzzles, Scrabble, Sudoku, and things like that. And a lot of people do crossword puzzles every day. That's great. That's wonderful. You need to keep doing that. Some centers are advanced enough that you can actually be referred to cognitive rehabilitation, or what they call cognitive therapy. So there are some centers in the country that have, just like physical therapies, they have therapists that work on cognition, which is wonderful if you have it available. Learning new information, reading, learning a new language, learning to play a new instrument, anything that challenges your brain is going to be helpful. Okay, adjusting your environment, using planners, calendars, lists, etc. All of that is exactly what you need. The worst thing you can do is watch TV all day and not stimulate your brain. Okay, because that is gonna make you develop more atrophy, just like muscles. I always encourage my patients to exercise every day. Even if they're sitting in a wheelchair, I want them to exercise at least 15 minutes in the morning, or 10 to 15 and 10 to 15 at night, work on their core strength, things like that, and also do some memory exercises because it's important. Remember, for MS, for things not to get worse, sometimes it's the best we can do. But if we don't exercise our brain and our muscles, they are going to get weaker. And then we are going to assume is MS getting worse, and it wasn't. Okay, so don't forget that. Next. A brain healthy diet makes a big difference. So things like the Mediterranean diet, um, that is helpful. High cholesterol, not so much. So low fat, low cholesterol diet is good. A diet rich in dark vegetables, fruits with antioxidants, etc. It's good. Some alcohol, 3 glasses to 5 glasses of wine a week. It's good for your brain. More than that, it starts becoming a bit of a poison, right? So everything in moderation. So the healthier that you eat, the more antioxidants, etc. That's definitely going to help protect your brain. Exercise. I'm sorry. Next. Staying physically active as much as possible, like I was talking about. Even if you happen to be in a wheelchair, you want to exercise and you want to get that oxygen in your brain, because good blood flow is going to make you better, and it's going to encourage new brain cells. So believe it or not, we are able to create new brain cells our whole life. So it's important to remember that. And also, not just because people have MS doesn't mean they're immune to heart attacks, stroke, diabetes, and other problems. So the healthier that you try to become, the better you will do. Next. Again, I mentioned this before, remain socially involved. Many studies have shown that if you isolate yourself, you will not be as healthy, and it will affect your memory. So the more you talk to your friends, the more you stay active with your family, not only your stress levels will be lower, but you will have healthier brain connections. And even if you have to do it using a phone or using Zoom or using a computer, because we cannot see our families right now, or it's not as easier because of this pandemic, still do your best to stay connected. Next. And we talked about these activities. There's a new cognitive training program. Is called Brain HQ. Okay, just like it sounds, brain and then an H and a Q. If you Google Brain HQ, you can actually sign up for it. And I don't know how much they charge, but it was created by scientists. And it's been studied in MS. And I'm actually going to use it for one of my research trials if I get the funding. So it's you can actually try it for free, and then if you like it, you can sign up for it. It's absolutely worth the trying it and using it, and it stimulates your activities, so your brain cells and your brain activities. So keep it in mind. Brain HQ. I'll put it on the chat. Next. So in conclusion, over the last decade, much has been learned about cognition abnormalities associated with MS, including what it looks like on MRI. But we need now is to find effective treatments. And there's a particular substance that I didn't talk about, which is Ampera, or actually dalfampridine, which some of you may be familiar with. And that one has been studied a lot lately, and it is looking hopeful. So keep your fingers crossed that we get some funding to study Ampera for the treatment of cognitive impairment, and hopefully get it to be FDA approved for that. But in the meantime, if you are on Ampera and it's been prescribed to you to improve your ability to walk, then it may be helping with your cognition and your ability to think, which is what we think is happening. So with that, I'm gonna go ahead and stop, and I think we have time for a few questions. I apologize in advance. I'm not going to be able to stay too long because one of my dogs had surgery today, and I have to pick him up before they close the vet. So I'll take a couple questions.
All right, thank you very much for that, and we'll keep it brief. Let me just let all of our participants know you can use the chat to ask questions. If you touch your screen or click your screen, there will be a chat button on the bottom, or you can use the raise hand function. If you're on a computer, that's going to be at the bottom of the participants window. And if you are on a mobile device, it's going to be under the More button. All right, so let's see. I see that you've answered the first question there, which was with COVID restrictions to in-person visits, can the SDMT be administered in a telehealth visit? And you've said, yes, SDMT can be administered by Zoom. Anu asks, what was the name of the medication you mentioned at the end to improve cognition?
So it's Ampera or dalfampridine, which is FDA approved to help with ambulation or mobility impairment in MS. And it's been studied for cognition, and it seems to be helpful, not for everyone. It's kind of like with ambulation, but definitely it looks very, very promising. So our team submitted a proposal to the Department of Defense to study Ampera in combination with Brain HQ or cognitive training versus cognitive training alone, so that we can see if people do better when they do Ampera or dalfampridine, which is the generic, dalfampridine and cognitive training versus cognitive training alone. So it will be a 3-year study. So keep your fingers crossed that we can get to do that study, because we will also include MRI to look at some of those findings and some changes, and see if Ampira or dalfampridine is actually improving your ability to make connections, which is called brain plasticity. I hope that answers your questions.
And Stephen asks, do you refer patients to OT for cognitive rehab? And Sherry mentions that speech therapists also do cognitive retraining. So where would a person typically go if they needed cognitive rehabilitation?
So they might want to ask their physician if they know of a specific place around their area that does some cognitive training. But again, like someone mentioned, who was that? Sherry, that speech therapy can also do some cognitive retraining. And again, you don't need someone too sophisticated. You can do your own cognitive rehabilitation at home with crossword puzzles, uh, playing Scrabble, etc. So, but ask about it. If your neurologist doesn't know, you can call a few of the physical therapy places and find out if they have any cognitive rehabilitation available. So, okay, I have,
David has a question. David, go ahead and ask your question.
Yes, hi. Good presentation. I would like to know, out of all of the relapse and remitting, primary progressive, secondary progressive, and progressive MS, which one of those would have cognitive issues?
will help. Is
Pardon?
that what you asked? You asked me which
No, I'm
ones?
asking which one of those, once when someone is diagnosed with it, which one of those have the cognitive issues, or is it all?
All, but more in the secondary progressive.
Oh, okay.
Thank
But
you for
that
your
doesn't mean
question.
that not everyone with secondary progressive will develop cognition problems, but we see it more often in the secondary progressive phase.
And we have a comment from Carol. She says, I have primary progressive MS, and I was told in 2004 that symptoms are usually waist down. So I was surprised to hear you say otherwise, but I definitely see cognitive impairment. So I think you are right.
I hope I'm wrong about you, but it wouldn't hurt to talk to your neurologist about it. Absolutely.
All right. Well, that's all the questions that we have, and we know that you have a sweet pet to pick up. So we'll close there. And thank you very much for braving the snow and making the time to be with all of us and present this information.
It was a pleasure. And let me know if you thought this was useful, or if there's anything else that you think that you wanted me to talk about. Hey, Alan, how are you?
Thank
So,
you.
How are you? Just want to say thank you.
welcome. You're welcome. Okay.
It was very helpful.
I'm glad. And I promise I wasn't planning on having a snowstorm or for my pet to have surgery. They decided to have surgery yesterday. So again, I apologize, but I'm glad we were able to do this.
Yes, thank you. Thank you. Thank you. It was wonderful.
Take care.
So, on behalf of MS Focus, thank you to all of our audience for joining us today, and Dr. Flavia Nelson for such a wonderful presentation. And I'll say good night to you all. Good night, everybody.
Night,
Good
night.
night.
Night, Casey.
Thank you.
Good night.